What is going to be the presentation or the scenario? So as we know that this placenta previa is going to cause antepartum hemorrhage, that is bleeding after the 28th week of pregnancy. So since this is the lower uterine segment, right, and the placenta is present in this lower portion, okay, let's say over here, and the baby is right over here, okay, over here, let's say this is just a hypothetical diagram. So this placenta is present in such a lower level that the pressure from above can cause it to shear, and even mild uterine contractions can cause it to shear off, okay, to shear off from its location, or just bleed. Some minor bleeding can also occur. Now how are you going to diagnose this case from a scenario based on the nature of bleeding? Okay, how is the bleeding? So this is something you should listen to very carefully. The bleeding is going to be bright red in color, okay, bright red, and it will be of course a fresh vaginal bleed. Okay, compare it with the bleeding of placental abruption, which is brownish in color. Okay, so that is brownish in color. And whether pain is present or not, there is no pain, this is painless. Okay, compare it with severe pain of placental abruption. So you have to basically differentiate it from abruption. So I will just point out the features of abruption right here. In abruption there is brown bleeding, and it is severe, severe pain occurs, and tender uterus is there, so we call it a woody uterus. Okay, but in case of placenta previa over here, this is a separate topic, so I'm marking it in brackets. There is no pain, and the bleeding is fresh vaginal bright red bleeding. This typical scenario, the telltale scenario is that the female wakes up in a pool of blood. Okay, this can be mentioned in the question, that she woke up in a pool of blood. So this can help you diagnose no pain and fresh vaginal bleeding. Now, how are you going to approach the patient? The patient comes to you. You are going to, first of all, you have to, since there's a case of antepartum hemorrhage, so first of all you are going to resuscitate the patient, vitally stabilize. You can give fluid resuscitation and just stabilize the patient. Okay, follow the ABC protocol and resuscitate the patient. Now you are going to take history, so all the points of the scenario that I mentioned, woke up in a pool of blood and fresh bleeding, no pain, and then now you're going to examine the patient. So attempt the question in order, don't just write treat it like this. No, when they give you a question, do the whole, if even if they ask you only the treatment, okay, then still write the whole approach. The approach to the patient is a part of the treatment. Now you're going to examine the patient. So on abdominal examination, what is going to be happening is that the uterus is going to be painless and relaxed. Okay, unlike the woody uterus of placental abruption. So painless uterus is going to be there and relaxed, and fundal height is going to be normal, equal to the age of gestation. Now, there can also be malpresentation, okay, unless there's a malpresentation, a breech presentation, then the fundal height will of course be less than the age of gestation. Now, vaginal examination. This is a very important point, that vaginal examination is never done. Please remember this, never do a vaginal examination of a patient, because the placenta is already present in the lower part, and if you examine the vagina, poke the probe or you poke the speculum, you are going to make the situation worse. Severe bleeding can occur and the patient can die. Okay, so never do a vaginal examination unless you have ruled out placenta previa. So what is the investigation of choice for placenta previa? The investigation of choice is transvaginal ultrasound. Okay, transvaginal ultrasound is safe, even safer than speculum examination. So they want you to tell this in the exam and in the viva, that never do a vaginal examination if you are suspecting placenta previa. First, rule it out. How are you going to rule it out? Via a transvaginal ultrasound. Okay, so this is how you are going to diagnose, on the basis of abdominal examination, history, and transvaginal ultrasound. Vaginal examination, you cannot do it. Now, how are you going to manage placenta previa? Now, basically for management, we have two options. We have the conservative option of management, okay, and we also have the surgical management. So in conservative management, what we are going to do is that we are going to follow a protocol which is known as the McAfee's protocol. I don't know the exact spelling. The McAfee's protocol. So in this, for conservative management, there are specific requirements. Okay, the case should be a safe case. How are we going to define a safe case of placenta previa? The mother should be stable, okay, and less than 37 weeks of gestation, away from term, and there should be no active bleeding. Okay, Otherwise, if she is bleeding severely, you are not going to just ask her to rest. She's going to go into hemorrhagic shock. Okay, just be careful with that. And the fetus is also healthy. However, you're going to tell the fetus is healthy, the reactive CTG, non-stress test or CTG is going to be reactive, normal. So the mother and baby both are safe away from the end date of delivery, less than 37-week gestation. And so then we are going to do the conservative management. Okay, what is involved in conservative management? The conservative management involves bed rest. Okay, and all the investigations you're going to do, you're going to do, inspection of vulval pads. You're going to, vulval pads, so that you can see how much bleeding is occurred, place pads. And then you also have to give supplementary hematinics. Okay, iron supplementation, so iron and B12 and folic acid supplements. And you also have to do, you can do gentle speculum examination, but don't mention it because it is, contraindicated in placenta previa. Now, surgical management. What are the indications for surgical management? The opposite of the conservative management. If the patient is unstable and if it is more than 37 weeks of gestation, okay, all these things, if she continues to bleed, if there is any sort of fetal distress, or if there is a dead baby, sadly, then you have to do surgical management. What is the surgical management? You are definitely going to go for a C-section. Okay, you can see, so you have two options for management, either McAfee protocol or C-section. And for McAfee protocol, you require complete stability. But if the patient comes to you in an unstable condition, you don't have a choice other than doing a C-section.